Let me now turn to introducing Dr. Barbot, giving greetings on behalf of the City Health Department. Dr. Barbot is also a pediatrician, and she has tremendous experience and accomplishments in this area, far more than me. She was the head of school health in New York City. She was a pediatrician in the Community Health Center in Washington, D.C., and she has focused the city's attention on really making concrete progress in a number of important areas, including asthma. So I think it's terrific that she's here, that I am looking forward to close collaboration with the city as we make progress on asthma. So thank you all, and good luck today.
Good morning. Good morning.
Good morning.
All right. Thank you, Josh, for that very gracious introduction. I think my caffeine still hasn't kicked in. It's always a pleasure to be in a group of individuals like this who are committed to asthma. And before Josh leaves, just really want to reiterate a great thanks for the commitment that Josh has to reducing health disparities, not just in Baltimore City, but across the state. And we are strong partners with him at the state. So we're looking forward to even greater leadership from Josh. He's got a great history as Baltimore City Health Commissioner, and he's going to have an even greater history as Secretary of Health for the state of Maryland. So thank you so much, Josh. So it's a pleasure to be here with you all today to talk about disparities in asthma care. And clearly, I don't need to tell you all this, but I'm going to say it anyway, that asthma is a serious chronic lung disease that is controllable with access to quality health care, education, and reduction in triggers. And the thing about asthma that we know is it's not one of those things where you don't know if you have it, you're not clear what to do, and the science is not clear. Asthma is just one of those obvious things. You know when you have asthma, you can't breathe. The science is clear that the quality standards of care for treatment protocols are clear, and we're clear about what works with regards to education. And Josh said it very clearly that really the issues are when it comes to implementation, when it comes to helping providers practice according to national standards of care, helping parents implement preventive measures, and teaching kids how to self-manage and how to recognize when they need to ask for help. And so in Baltimore City, we have an estimated 64,000 adults who have been diagnosed with asthma at some point in their lifetime. And in the child population, we've got about 19,000 who have been diagnosed with asthma at some point in their life, and that's about a 14% prevalence. Depending on the literature that you look at, the prevalence in Baltimore City, especially for African American youngsters, can be as high as 25%, and that's significant. The average mortality rate due to asthma is more than twice as high in Baltimore City as the Maryland rate, and so 34 deaths per 100,000 people versus 14 deaths per 100,000 people. When we look at the disparities in outcomes related to asthma in Baltimore City, they're really alarming. And so African Americans get hospitalized at an overall rate 3.8 times greater than the white population in Baltimore City. And when you look at those aged 18 to 44, the disparity is 5.7 times greater. And the point there is, there's really no good reason for that. African Americans utilize emergency departments at an overall rate 6.1 times greater than whites in Baltimore City. It's 7.6 times greater when you look at those aged 5 to 17. And those are preventable ED visits, preventable hospitalizations. And that's why in April, Baltimore City Health Department released Healthy Baltimore 2015, our health policy agenda for the 10 priority areas accounting for the greatest level of preventable disease, disability, and death. And within each of these priority areas, we include leading indicators with aggressive and achievable benchmarks for improvement. Because it's imperative that we hold ourselves accountable for demonstrating measurable outcomes, measurable successes. And asthma falls within our first priority area, which is promoting access to quality care for all. Healthy Baltimore 2015 makes clear that working in silos isn't going to cut it any longer. And in order for us to make significant strides in reducing disparities and inequities, we need to consider how where we live, work, learn, and play contribute to our health outcomes. And as Josh mentioned, asthma is a great model for illustrating this point. So true, we need more people to access quality health care and have treatment plans that are in line with national practice guidelines, but we also need more people living in healthy housing and more people with more access to healthy transportation. And so I want to share with you some of the specific activities going on in the health department and in Baltimore City related to reducing disparities within asthma. So one of the new things is, in collaboration with the Baltimore City Public School System, this coming school year, every family with a child who has asthma is going to receive a letter from the Health Commissioner telling them, urging them to let us know if their child has asthma. Because that's step one, right? If we don't know who has asthma, we can't then engage them in case management. And when I was medical director for the New York City Public School System, this was a very basic activity that made a significant difference. It alerted parents to the fact that it's important for us to know when your child has asthma, because there are specific interventions that we can offer that will help your child stay in school, stay out of the ED, and interact with all of the educational activities that are available through schools. And so, in addition to asking parents to let us know when their child has asthma, also encouraging them to see their provider sooner rather than later so that their provider can write a script for a rescue med in school and write for an asthma action plan. Very simple, basic things. In addition, they will get a letter addressed to their provider, urging their provider not only to let us know when the child has asthma, but also to indicate the severity and to remind the provider that national practice guidelines called for inhaled corticosteroids when a child has persistent asthma. And again, our experience in having done this in New York City is that over the course of about 2 years, we were able to significantly increase the number of children who were on inhaled corticosteroids to the point where there was no statistically significant difference between children of color and white children in terms of meeting practice standards. And that's significant, and that's what we want to do in Baltimore City. In addition, working through our school health program, we're going to be tracking the outcomes. So what difference does it make? And so we'll be looking at the rates of walk-in visits, how often kids get to stay in school rather than being sent home because of asthma flares in schools, EMS calls, as well as absenteeism. And then also working through our schools, we are going to be implementing the asthma-friendly school initiative. And so to date, we've got 30 plus schools that are asthma-friendly. And in addition to meeting the criteria that I mentioned earlier in terms of having asthma action plans and rescue meds in schools, this program, the schools have to meet proactive maintenance of buildings and school facilities to reduce asthma triggers and improve indoor-outdoor air quality, as well as providing asthma education for students and staff. And so we have, in addition to working with the schools, we're also working on the environmental aspects of asthma, and we've got an excellent home visiting program funded through a comprehensive CDC translational research grants and state funding, which provides asthma home visiting for kids 2 to 18 years of age and reaches the kids who are most at risk in Baltimore City. The program provides a coordinated approach to asthma education, including environmental home assessments, asthma trigger reduction, and communication with the child's medical team through a report after each home visit. And so to date, we've reached over 500 kids and have demonstrated significant improvements in outcomes, such as reduced ED visits, reduced hospitalizations, improved school attendance, as well as reducing the overall burden of homes in terms of cockroach infestations as well as mice infestations. And then we've got a newly funded Healthy Environments, Healthy Kids from the APA, which will provide training of and direct services to community-based partners engaged in improving environmental health for children in Baltimore City. And through this grant, we will improve outcomes through inspecting and training for city-based Head Start programs and child care providers focused on environmental and health hazards in those settings. We will also provide training of key home visiting staff on healthy home fundamentals, and we will provide training for WIC and other community-based partners, as well as integrating healthy homes and community principals into training and certification programs for licensed child care providers. And so it gives you a sense of, through Healthy Baltimore 2015, not only for asthma, but for all of the other priority areas, the importance that we place on breaking down silos and working across the spectrum of the various sectors of society that impact on this particular issue. And so specific to asthma includes not only working with providers and hospital systems, but also working with community-based organizations, as well as the school system and parents as well. And so I'm hopeful that this conference presents an opportunity to learn about even more opportunities to reduce health disparities and to come together as a call for action in making a difference in these asthma outcomes for all individuals with asthma. And so without any further ado, I'd like to now introduce the segment of the human aspect